Welcome to The Scoop, NANP's monthly educational webinar series. I am your host, Andrea Granson, Education Program Specialist for the NANP. These webinars are recorded and can be viewed at any time by logging into the NANP members area. NANP members can earn 1 continuing education credit for participating in Scoop webinars by taking the corresponding quiz, which can be found in the membership area of the NANP website. Okay, so let's get started. Today, we present using 2-3/targeted thyroid supplements to improve client outcomes with Dr. Amie Hornaman. Dr. Amie Hornaman, a.k.a. the Thyroid-Fixer, is a woman on a mission to optimize thyroid patients around the world and give them their lives back using her proprietary transformational program, the Fix method. She is also the founder of the Institute for Thyroid and Hormone Optimization. After her own experience of insufferable symptoms, misdiagnoses, and improper treatment, Dr. Amie set out to help others who she knew were going through the same set of frustrations and who were on the same medical roller coaster. She grabs your hand, gives you answers about your health that no one has told you, and gives you the actual tools and personalized treatment to fix you. What makes her program unique is the extra support and accessibility that you can't find anywhere else. That's the transformational journey, with a focus on optimizing thyroid and hormone function and thus optimizing her patients. Dr. Amie looks at you as a unique individual and not just a lab value. She examines all factors that tie into thyroid dysfunction and thyroid symptoms and fixes you to give you your life back. Welcome, Dr. Amie. Thank you so much for joining us today. It's now over to you.
Oh, thank you so much, Andrea. I look forward to this. So hopefully all of you will be learning something new and something that you can put in your toolbox to improve your patient outcomes. So let me start sharing my screen. We'll go through this. Here we go. Okay, I'll minimize us up here. Okay, like Andrea said, we're going to discuss using T3 thyroid targeting supplements to improve client outcomes. What we're going to really focus on today, and many of you I know what thyroid symptoms are when your clients come to you. We're going to review those. I really want to focus in on T3 as the active thyroid hormone. It's powerful to make changes in your clients' symptoms, in their body, in their health, and their overall health, no matter what they're dealing with. We're going to talk about medication versus supplements, the different supplements to use, and then something you may not have heard of lately, T2, which is just the new player in the game of optimizing thyroid. And it's something that you can actually use with your clients, even if you're not a prescriber. So we see this in practice all the time. I know all of you have seen this over and over again. This subclinical, and a lot of people don't even like to use that term, subclinical. They like to go right into, hey, you have hypothyroidism, you have Hashimoto's. But conventional medicine still uses that term subclinical, where people are coming in on that borderline, but they still present with 1, 2, or all of these symptoms. You'll hear weight gain, the inability to lose weight. They'll tell you they're doing absolutely everything. They're eating right. They're going to the gym. You've heard this over and over again, I am sure. Fatigue, hair loss, anxiety, a low libido. Insulin resistance is huge when it comes to hypothyroidism and Hashimoto's. I see insulin resistance in about 99% of my patients. Constipation, GI issues, insomnia, even joint and muscle pain. A lot of people don't realize that their frozen shoulder can be tied back to a non-optimized thyroid because the thyroid is the master gland. Joint and muscle pain, urticaria, histamine intolerance. And this is just a small list. This is just touching on some of the symptoms that your clients will be presenting with. And I think it's important to go over the labs to have ordered. If you can order them, if you have your clients order them from and order your own lab test site like Alta Labs, or if you can get them to get their prescribing PCP, GP to order these labs so that you can get the full picture and you can kind of know what you're dealing with as well. It's important to go over the functional optimal labs. And in my functional medicine training, this is what I learned, and this is what I've seen over 26 years in practice. And looking at so many different thyroid labs, we really have to kind of use this as a guide. And then at the end, when we're going over case studies, you'll actually see how to apply it. And even if you guys know, even if many of you know the optimal values already, I think it's important to deep dive into this because you're going to learn something new today. I promise you. So TSH, the optimal level is below a 2. Now you will hear some functional practitioners say we want it between a 1 and a 2. This is what I do. So trust me on this one. The TSH is going to drop below a 1 if you have them on if they're on T3, if you have them on an NDT, natural desiccated thyroid medication, or what we're going to talk about today, glandular supplements, those contain T3. And any time T3 comes into the body, and we almost have to go back to basic physiology. And quite frankly, I see this mistake being made in the medical system as well. So if any of you can prescribe, you have prescribing rights, listen up, because this is going to open your eyes to treat your patients better. That TSH will absolutely become suppressed and drop below a 1 if they are on any kind of T3, because the pituitary senses that everything is well. So it doesn't have to yell at the thyroid. And if everything is well, it might go below a 1, but that does not mean that they are hyper. They can still be hypo. So this is where we paint the whole picture. And then we move on to free T4. It's the inactive hormone. Let's remember this. I see this from my patients going to their PCP or to their GP. And they say, oh, well, here you go. Here's some T4 medication. We're only going to test TSH and free T4. Good to go. No. Free T4 is the inactive thyroid hormone. It has to convert over to T3 to get into the cell. So I really like to see that at 1.5, or unless they are on T3 medication, and we'll get into those kind of different scenarios so that you can really know what you're looking at. Free T3, that's active. Every single cell in our body has a receptor site on it for T3, every single cell. So that is the active thyroid hormone. Our cells only have receptor sites on it for T3. They don't have a receptor site on it for T4. So why are we focused so much on T4? Why are your clients coming in with a full thyroid panel? I'm using air quotes there. And all it has on it is TSH and free T4. It does not make sense because T3 is the active thyroid hormone. So we want it 3.5 or above, or the upper quadrant. I see patients across the US and in different countries. So when you're working with different countries, and even here in the US, the different labs will have different ranges. So you want that in the upper quadrant of the range. Now, I will also say that just because someone crests that upper limit, that does not mean that they are hyper. They can still, that could be their optimal. So if the range goes to a 4.5 and they're coming in at a 5 and they're like, you know what, I feel great. I've never felt better. I'm finally losing weight. I have energy to get through my day. My hair is growing back. I'm not depressed anymore. My sleep is amazing. Then that's their optimal. We don't call them hyper. If they don't present with hyper symptoms, we don't call them hyper. That is their optimal. So 3.5 or above in the upper quadrant, and sometimes over. That's where you really have to get that full picture. And then reverse T3, just as a reminder, reverse T3 is the brakes. Those are the brakes. So if T4 is having issues converting, it's going to convert to reverse T3. We really want that below a 12. And especially if they're on T4 only, which 99% of your clients that are actually diagnosed with hypothyroidism, they're going to be on T4 only. And we're going to get into that. There's so many barriers to conversion. And this is where you're going to dig really deep, and you're going to be able to guide them and help them and address many, many, many of these. Stress, high cortisol, estrogen dominance, insulin resistance, like we said, is so, so common. Leaky gut, which I'm sure you see all of the time in your practice, anemia, nutrient deficiencies, different surgeries, drug interactions like beta blockers, cancer drugs, lithium, some antipsychotics, all of those can raise reverse T3 and interfere with that T4 to T3 conversion. And again, I know a lot of this might be a kind of an overview for you, and some of it might be, you might pick up on something, but T4 has to convert to T3. T4 is inactive. It's the lack of T3. It's when that T4 is converted to reverse T3. It's that lack of T3 that really causes symptoms. Now, other things that you can do besides looking at the different factors, like we talked about in the last slide, besides looking at their leaky gut and their stress and their cortisol and their insulin resistance and what medications they're on, you also want to look at their selenium level, potassium. Iodine is a big one. We could do a whole different series and training just on iodine alone. That's highly controversial in the functional medicine world. It's pretty much split down the middle of people that say, no, don't give Hashimoto patients iodine. And over here saying iodine is important for every single cell in the body. But we know that it is important for the conversion of T4 to T3. Having proper iron levels, especially ferritin, the person not being anemic, vital. Proper zinc levels, doing a higher protein diet is often very effective at pushing that conversion of T4 over into T3. And then sometimes we use adaptogens as well, especially if they have any kind of cortisol or adrenal issue. Now, your clients are going to come in, they're going to be on, like I said earlier, 99% of them, they're going to be stuck on T4. I actually call it the synthroid box. So when I gave a talk to the integrative wellness physicians here in Erie, PA at LECOM, I said, why are you guys in the synthroid box? There are so many different types of medication for thyroid, supplements for thyroid, different combinations that we can do for the thyroid. Why just use one? And one of the doctors raised his hand and goes, that's all we've learned. Okay, but now it's time to think outside of the box, outside of that synthroid box. So these are all the just T4 only. These are T4 only medications that many of your clients will be on. But we have to remember that without T3 hormone, the body will shut down and eventually die. Now think about that. This obviously is not pounded into the conventional medicine system. It's not in medical schools enough. We're not focused on this enough. There is a lack of focus on this. And this is something you can absolutely bring into your practice, because think about this. Without T3 hormone, remember we said T3, there's a receptor on every single cell in your body. There's a ton of receptors on the brain, by the way, a ton of receptors on the heart. Without T3 hormone, the body will shut down and die. So think about the clients that you have that are coming in. You take their intake, you take their medical history, you see they had a total thyroidectomy. They had radioactive iodine. And then you go over here at their medication list and you see they're on T4. That's a problem. They have removed at some point in their life, or radioactive iodine blasted, a person's thyroid gland that produced T4 and T3. And they also removed the main gland that converts T4 to T3. So if we don't have T3, we die. It's pretty darn important to me. Pretty darn important to your client too. And that's a pretty powerful statement that I think we all have to remember. Many things can interfere with T4 absorption and conversion. We went through some of them earlier. Others, genetic SNPs. So many of you might be into genetics. I have not seen this test performed very often in the US. I see more of my UK patients have this test done, but it's DIO1 and DIO2. Those are two genes, genetic SNPs. I am by no means a genetics expert, so I apologize if I get any of these terms wrong. But those are two that, if present, it gives you an indication that this person cannot convert T4 to T3 very well, if at all. So genetic SNPs are one. We talked about medications, different medical conditions. So even if they are a full-blown type 2 diabetic and they're walking around with an A1C of a 7, an 8, their insulin's a 20, and I've seen this just recently, that alone, that high insulin level, will interfere with T4 to T3 conversion. Magnesium levels are vital, selenium, iodine, we talked about that, not being anemic. So we see this a lot with vegetarian clients, not being anemic. And anemia or low ferritin will absolutely interfere with T4 to T3 conversion. And then we talked about stress and even just the time of day, the food that they eat, doing coffee, doing PPIs, which so many people are on, if they take that too closely to their thyroid medication, they will experience absorption issues and conversion issues. So we talked about earlier about how your clients are going to come in and they're going to present their list of medications. And many of them, if they have a thyroid problem, if you know, walking in the door and sitting down with them and they say, I was diagnosed with hypothyroidism, I was diagnosed with Hashimoto's, you know that, then you look at their medication list, T4, T4, T4. And you might even see, as you talk to them or do their history, that at one point in time, they were on 88 micrograms of T4. And then the doc went to 112. And then they went to 125. And now they're up to 188. And I've even seen people come in over 200 micrograms of T4. Excess T4 will cause reduced T4 to T3 conversion. So we need that conversion. Remember, we need T3 or the body dies. So if we keep raising, and this doesn't even make sense when you talk it out and you say it out loud, if we keep increasing a person's T4 medication, all that's going to do is impair the conversion and make them worse, not better. So we're in this more is better kind of mindset in our society. More is not better when it comes to T4. It can actually make a person worse. I really only, and this is being generous, I will say this is being incredibly generous. 1 out of 20 patients do well on T4 monotherapy, meaning they're on T4 only. No supplemental intervention, no T3 in the mix whatsoever. Whether they have a thyroid, don't have a thyroid, I would say I should probably change this to about 1 in 100. It's very, very, very rare that you will talk to someone that is on T4 only, those list of meds earlier, and they will say, you know what? I am doing great. I feel amazing. My weight is stable. I can eat this and this and have a little bit of ice cream and some wine with my friends, and I don't gain weight. And my energy is great through the day. You won't hear that from a person that is on T4 only, I promise you. So we look at endocrinologists. Endocrinologists, many of your clients are going to be referred to an endocrinologist. My PCP referred me to an endo. So I go to the endo, and the endo just tests TSH and T4 and gives me T4. Endocrinologists actually know that T4 monotherapy artificially lowers free T3 on a chronic basis. So why are we doing it? Why are we giving someone T4 and then more of it if it's going to lower the very thyroid hormone that we need for life? It almost doesn't make sense when you think about it. So here's the problem. Most are given T4 only, then they're ignored. Here's Susie, here's your T4. Thanks, we'll retest you in 6 months. Susie leaves the office, she gets on T4, and this is really my story. So if you want to dig deeper into my misdiagnoses and the whole pain to purpose of why I'm in this space right now, I've been doing it for this long, is because if you do rewind 25 years, 26 years, however long it's been, I was misdiagnosed by 6 different doctors, and then the 7th one gave me T4. And just like many of your clients, I walked out of that office, I thought, okay, finally, I am going to lose weight. These 20 plus pounds that came on while I was actually competing in bodybuilding and fitness shows. So I was doing the diet, I was doing the exercise, and the pounds kept coming on. I left that office thinking my world is finally going to change. And 5 months later, not 1 pound came off. So most of the time, your clients are ignored, but they're given the T4 and then sent on their way. They continue to suffer with symptoms just like I did. And that's why they're coming to you for help, saying, please, here are all my symptoms. Somebody needs to listen to me. Somebody needs to help me. So with this knowledge today, you can take this and greatly improve their symptoms. Now, if you're working with their practitioner, maybe you're working with their PCP, or you have you have someone that prescribes, that is open-minded, that's part of your team, that's part of your community, that you can go to and refer patients to, refer your clients to. And you can say, hey, doc, I met with Susie and she's on T4 only, and we're looking here at the labs and they're not quite optimal. And she has all these symptoms. Could we maybe try a T4, T3 combo? Because here's T3, the active thyroid hormone. And this is what I did with doctor number 7. I went in after searching Dr. Google, or back then, maybe even microfiche at the library. I went in and I said, here's this T3. It's very, very powerful, as it turns out. And I'm learning more and more that T3 is the active thyroid hormone, but I'm on T4. This doesn't make sense to me. Can we do some T3 too? She goes, no, I don't do that. I go, well, I'm going to find somebody who does. So you might have to help your client find somebody who does, or like I said, we're going to get into the supplements as well. You can use those. But Armor, Nature-Throid, NP, I think Nature-Throid's gone now. NP Thyroid, West Throid. I mean, you might find this in a variety of different countries. And then compounded T4 and T3 is another option as well. Some of them might be on this already. So you might be sitting there going, well, yeah, I have Susie and she's already on Armor, but she's still not feeling good. Right. Okay. We'll get into that. Because those NDT medications are supposed to mimic the human 4-to-1 ratio of T4 to T3, but they don't always hit the mark, especially when they're compounded. I love compounding pharmacies, don't get me wrong, but in my experience, man, they can get it wrong sometimes. They can really get the mix and the dosing incorrect. And then you might have somebody that thinks they're on X amount, but they're really not. And it's just not that 4-to-1 ratio. And some people might need a different ratio. So we'll talk about that. The T3 meds, generic liothyronine, and then the brand is Cytomel, that is 3 to 5 times stronger than T4. So you're going to get really far when you add in anything with T3 in it. T3 can be added to T4. So you have somebody stuck in the Synthroid box, ask their doctor, hey, can we just add in a little bit of T3? Because it's really going to help. And I see that this person's free T3 level is not optimal. We're going to go over scenarios, not optimal, and they're suffering with all of these symptoms. Can we add a little bit of T3? Or can we change them to NDT? Do you think, this Susie's on Synthroid here. She's not doing so well. Again, list of symptoms, not optimized labs. What if we just use some Armor? And Armor is NDT medication that is prescribed, is from a drug company. So you'll have your client say, but I really want to go the natural route. I don't want to take Synthroid. I don't want to do this liothyronine thing that you're talking about. I really want to go the natural route. We go, okay, well, there is, yes, NDT is natural desiccated thyroid, but it's still manufactured by a drug company. So when your clients are saying that, you have to just educate them that it's still, yes, it is derived from porcine thyroid gland, but it's still made by a drug company. So it's not 100% natural. And they use fillers. And some people don't do well with the filler. So this is your job at kind of guiding the patient and hopefully working with, again, an educated, open-minded PCP GP that will work with you and work with your client to get them the best outcome. So we can add NDT to change the ratio, or we can use T3 just on its own, because there are T3 only people out there. I'm one of them. I do not convert. Never been tested for the DIO1, DIO2 gene, but through trial and error, which we will also get to, I just don't convert. So T3 is active. It binds to the cell. It activates metabolism. Now, we're not going to just use T3 to get somebody to lose weight. That's not the point. However, side note, they are using T3 in depression, and it's working a heck of a lot better than SSRIs. So T3 is really, really powerful for the brain. We're actually seeing there are studies out with bipolar and how T3 is so much better than all of the bipolar medications. Ironically, lithium, commonly used for bipolar, tanks the thyroid. So why not use T3, get the same outcome, and not send a bipolar person into hypo, which is only going to make them more depressed in their lows. So it helps with weight loss, increased energy, better mood because of all the T3 receptor sites on the brain. Some need T3 only. Like I said, I do. So it could be a genetic SNP. It could just be that you are a non-converter. We look at that reverse T3. This is why it's important to test this every single time they test. So whether you have to request it from their doc, you have to send in a message to their doc, send a message to your doc that's working with you, or if you can order labs yourself for your clients, make sure you order reverse T3. It's vital, because if that goes up, if that goes above a 12, if that's hitting and actually getting flagged, let's say 20, 24, 25, 26, that's a huge red flag that they are not converting T4 to T3 properly. Now, sometimes we'll see this on a teeny tiny amount of T4, teeny tiny amount. So we talked earlier about changing the ratio. They could be on 25 micrograms of T4. and still have an elevated reverse T3. They just can't convert. The other thing is trial and error. That's how I found out. So I was on T4 and T3 separated. So I was on Synthroid and leothyronine. Through the help of my functional doctor, who basically brought me into this space and is my mentor, there was a point in time where he goes, I think your T3 is just so low. It's still so low. Let's increase the T3 and let's decrease that T4. And then he gave me the idea, which I have found with many of my patients as well. You know what? Pull out that T4 for a little bit. See how you feel. This is the trial and error part. Pull that out. Okay, you got better. Now put it back in. Oh, hypo symptoms came back and you gained weight. Now pull it out again. Now put it back in. And after you do that a couple of times, you actually start to realize that I don't convert. I get worse. And this is where, again, like we said earlier, more is better. No, it's not. Yes, you're giving me more thyroid hormone overall. The dose is higher, but it's not better. So more is not better. Cells that express D3, this is a type of enzyme that converts thyroid hormone within our cell, will inactivate free T4 and push it over into reverse T3 while also inactivating circulating free T3. That's a problem. That's why we have to test reverse. We have to say, is there something going on here? Is there something going on that is pushing T4 into reverse T3 and putting the brakes on this person? This poor person is presenting with every single thyroid symptom, and yet they're being told that they're normal and everything's fine. You're normal. You're normal, quote unquote. Labs are within normal limits, WNL, air quotes. And that's just not the case when you really dig and listen to the person and then pair up their symptoms with their labs. So as free T4 rises higher in reference range, so this is where we came back to the labs. Remember I said free T4 optimal 1.5? Unless they're on T3 medication, then we actually want that a little bit lower. As free T4 goes up, and remember, if their general practitioner or their endocrinologist is just testing TSH and free T4, this is where they could really be left in the dust, because that free T4 will go up and the doc will be like, oh, everything's great. Your numbers look fantastic. But that free T4 keeps going up, up, up in the reference range and sometimes above. Then T4 to T3 conversion will drop lower and lower. Nobody's testing their reverse. Nobody's testing their free T3. They're being told they're fine. It's basically medical gaslighting because they're thinking that they're crazy. They're like, wait a minute. Everybody keeps telling me I'm normal. I'm fine. My labs look good. Really? They look good? Well, I don't feel good. I feel like crap. So this is the perfect scenario of why we need to test everything every single time. Use T3 therapy. So this is where you can come in. Use T3 therapy or work with your client's prescribing physician. Start with 5 micrograms twice a day and work up. And so you want to monitor their vitals. You want to have them monitor their vital signs. So heart rate, that should be HR, heart rate, blood pressure, temperature, symptoms, and labs. I tell my patients, take your temperature. If you can get an old school mercury thermometer, that's golden right now. Don't use a digital, or just at least get a non-digital thermometer. And before you take your thyroid medication in the morning, as soon as you open your eyes, before your feet hit the floor, you put the thermometer in your mouth and you take your temperature and you record it. What we want to see, what you want to see in their tracking, is a gradual increase. So if they're getting better and coming out of hypo, so think hypo is low and slow. Hypo, low and slow. Everything is low and slow. Their gastric motility is low and slow. Everything is low in the metabolism. That's why they're gaining weight. That's why they're complaining about brain fog. That's why they have no energy. Everything is low and slow. So everything should start to come up. Heart rate should start to gradually come up. Blood pressure come up. Temperature come up. Temperature might not ever crest normal, but you should see it trend upwards. So right now, if they're 95.9, maybe they actually hit a 96.7 or 97.1 as they are improving. And then you pair that up with the symptoms and labs. Now, one thing I will mention about heart rate, I get this all the time. I guarantee you will get it too. Oh my gosh, my heart rate, it's pounding out of my chest. It's going too fast. I go, what is it? They look at their Apple Watch, they go, well, it's 80. I go, well, yeah, that's normal. You're walking around, it's the middle of the day. Like that's, yeah. Because you probably used to be at 50 and you weren't at an athletic 50. You're not Lance Armstrong. You're hypothyroid and everything was too slow. And now it's actually coming into normal, and perception wise to you, it seems high, it seems fast, but it's not. So that's just a little side note, because I guarantee you'll get that if you work with thyroid patients. So we talked earlier about total thyroidectomy, radioactive iodine, partial thyroidectomy. You're taking out half of the thyroid gland that used to produce T4 and T3, and that helped convert T4 to T3. So these clients experience issues because they lose T3 during T4 monotherapy. Remember, we talked about that. You put these poor people on T4 and their T3 just goes down, 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 and they feel worse and worse and worse because they can't produce it themselves anymore. They can't convert very well anymore. And they're just given T4 monotherapy, which we said earlier reduces T3. All right, so here's where the glandular supplements come in. And I'm going to tell you a little secret. I said this about 10 years ago. No, I said this about 20 years ago. There was a supplement out. It was the first glandular I ever saw. It was by a company called Vinco. I don't even know if they're still around anymore. Vinco, thyroid gland. You turn it over, bovine thyroid glandular. Now there's a ton of them. My favorite is actually ancestral supplements. They have a beef thyroid gland, and it's glandular and actually says 30 milligrams. So you know exactly what you're giving your patients. We'll get into that. I said this 20 years ago. I am waiting for the FDA to figure out. Now they have much better things to do, but I'm waiting for the FDA to figure out that glandular supplements are the exact same thing as NDT prescribed medication. Most of them. Now, I say that one day after I met with a patient who showed me this glandular supplement that she was on, and I could not figure out heads for tails on that one because it didn't have the amount listed. It was the proprietary blend. It had thymus in it and adrenal in it and thyroid in it. So you couldn't really tell. But if you have something like ancestral supplements that is just beef, thyroid, glandular, and Dr. Weston Childs has one too, it lists on there 30 milligrams. So just like we are taking a pig thyroid gland, taking it out, drying it out, putting it in medication, calling it armor, calling it NP. Over here, we are taking a cow thyroid gland, taking it out, drying it out, crushing it up, making it into powder, encapsulate it. Same thing, sold by a supplement company. So when you're using these with your clients, you have to be careful. You have to be cognizant. You have to know that this is going to move numbers. It's going to make them feel better, but this is where the education comes in because you have to know what you're doing. They are going to work like medication. They are going to work like medication. So those have pros and cons to it, right? If it's going to work like medication, your client can get side effects. If it's going to work like medication that they can't quite get from their PCP or from the doctor that you're working with, then this could make huge, huge strides in improving their overall outcome, improving how they feel, reducing symptoms. And we're going to get into the different types that I like too, but I want to introduce something that might be a little bit novel for you, T2. So this is 3,5-diiodo, say that 3 times fast, diiodo L-thyrine. When you look at the studies on this, it's actually amazing. And this is supplement. So this has actually emerged as a biologically active iodothyronine, meaning it's another thyroid hormone. So we talked about T4, we talked about T3. This is T2. You will find T2 in NDT medication. You will find T2 in glandular supplements because it's part of the thyroid gland. So when we dry a porcine or bovine thyroid gland out, there's just natural T2 in it. We don't know what amounts are in an NDT or a glandular supplement, but we know that they're there. So when we extrapolate that T2, we can use it on its own to also improve outcomes. So what we're finding in the studies, mitochondria, bioenergetic mechanisms seem to be major targets of T2. Chronic administration of T2 into cold exposed rats increases energy, increases capacity of the heart, skeletal muscle, liver, and brown adipose tissue. So that's what's going to help them lose weight. Chronic administration of T2 into rats induces significant stimulation of lipid B oxidation. And the effects of T2 on energy metabolism has prompted even more research in how we can use this to improve. I mean, we're in a state of obesity right now. We've been seeing this increase for years of obesity. It's getting into our kids now too. So this could be an answer to improve adiposity and associated disorders like insulin resistance and type 2 diabetes. So remember, these are the add-on or the standalone supplements that you can use to improve your client's outcome. The grass-fed natural desiccated thyroid, that's ancestral supplements. And I actually did put the link too. So when you get these slides, you can click on them. Weston Child's raw thyroid glandular. Both of those are my top favorite. You might have another favorite. You might have a favorite company that you go, well, Dr. Amie, you know, there's this company that I've been using for a while and they have a glandular. That's fine. But know the milligrams so that you can control for that. So if it's 30 milligrams, that's a great place to start, by the way. So many of your questions might be, well, where do we start with these glandular supplements? Most of them, are 30 milligrams. You don't want to start somebody on 60 or 90 because just think about it. If you were a patient of mine, you come to me, I'm not going to start you on a super high dose where you're going to be like, oh my gosh, I'm crawling out of my skin. I'm anxious. I'm going crazy here. That's moving into a hyperthyroid state very quickly. And I've seen this happen even with medication where a doctor will start somebody on too high of a dose out of the gate and they go, oh, well, I couldn't take that. No, it's not that you couldn't take it. It's that you started too high. So start with 30 milligrams. That's why I like ancestral. Start with 30. You can work your way up. Now, here's another thing that I didn't put in the slides, but I want you to write down. It is best to split dose anything with T3 in it. So this is where you can also help your clients. Your clients come to you, they go, well, yeah, right now I'm on 90 milligrams of Armour. You okay? Oh, okay. Well, that's good. I mean, how's that helping you? How's it improving your symptoms? What's changed since you started? Oh, by the way, are you taking that just once a day? Or does your doctor have you taking it twice a day? They go, I'm just taking it once a day in the morning. So you go, no. See, with anything with T3 in it, NDT medication, one of these glandular supplements, we want to split it. We want to split dose. So you want to take that first thing in the morning, yes, but T3 is very fast acting. It peaks at 4 hours. It's in and out of the system around 8 to 12 hours. You want to do a second dose. Now, does it have to be exactly 12 hours? No, because T3 can also keep you awake. So you want to have your clients take it first thing in the morning, and then you want to have them take that second dose between like 1 and 3 p.m. Some people can go a little bit later, but if you do, if your client already has sleep issues, that's probably not an area that you want to tread in. So just have them take it like 1, 2, 3 p.m. And that will give them that second dose of T3. So as the first one's kind of come down the one side and leveling out, you're giving them a second dose of T3. Again, metabolism, brain, energy, mood, cognition, motility of the gut. All of that depends on proper levels of T3. So you want to split those. That was just a little side note that I thought I'd throw in there. T2 supplement. So my T2 thyroid supplement is called the Thyroid-Fixer. Will be out by the time you're watching this. And then I got my inspiration to do this particular supplement from a company called Chaos and Pain, and they make a supplement called Cannibal Claw. Now they are targeting bodybuilders, powerlifters, gym dudes. So I have found over the years that it's a little bit difficult to tell a 40-year-old woman struggling with thyroid, struggling with all those symptoms, to please go on a website called Chaos and Pain and buy a product called Cannibal Claw. They're going to be like, what are you telling me to do? What the heck is in this? So I was using this particular product with my patients. I have been for years, and it provides such amazing outcomes. I can't even tell you. So I actually went to the company and I said, I want a private label because I can't sell Cannibal Claw to my 40, 50, and 60-year-old thyroid patients. But I can sell the Thyroid-Fixer, and it's the same thing. So I white labeled it, private labeled it. That will be out or is out by the time you're listening to that. So those are the two T2 supplements. And you can always go to my website, dramihornaman.com. I have the store on there. So those are the two T2 supplements that you can add on. And if your question is for any of them, the glandulars or the T2, well, what about the side of it? What should I tell my client to look for? Okay, you know that you're using too much, and this is more for the glandulars. You know you're using too much if they report back to you that they're just that hyper state, that my heart rate's up and I'm breathing heavy and I feel like I'm crawling out of my skin and I'm anxious and I'm not sleeping and I have diarrhea. Okay, well, that's a little bit too much. You want to back down on it. Not so much of a side effect of T2. T2 is less powerful than T3, more powerful than T4, but it's not going to produce those hyper symptoms like we can produce if we give someone too much T3. So using the T3, T2, or glandular supplements, this is going to help you reduce the reverse T3, the brakes, take the brakes off, put the gas on, take the brakes off. Increases free T3, decreases antibodies. So your thyroid antibodies, TPO, TGA, we didn't even go over those for Hashimoto's, but those are definitely part of tests that you want to test. You don't have to do that every single time, but you do have to do it once in a while because you will have patients that, and I know many of you cannot diagnose, but you will have patients that have never, ever, ever had their antibodies tested. And you will run them for the first time, or you will have them order their own labs, or you will have your prescribing doctor order them. And oh my goodness, there's antibodies. Guess what? You have Hashimoto's. Oh, nobody ever told me that. Well, it's because nobody ever tested for it before. But once you know, you just start implementing what you know to implement nutritionally, gluten-free, everything with autoimmune conditions to reduce those antibodies. But these supplements will help as well. It will decrease or suppress the TSH, and it will decrease symptoms. So the implications for thyroid therapy are significant. Whether we're using medication or we're using glandulars or we're using T2, when free T3 is kept below reference range or below individual set points on a chronic basis, as it is in uncounted millions of T4 monotherapy patients worldwide, we are in a hypothyroid state in many of our organs. So this is what I was saying earlier, such as the heart, that depend more on circulating T3 than on locally converted T3. So T3 can be converted in the tissues themselves. We said the thyroid gland is the major converting gland. That's where most of T4 to T3 conversion happens, but it can also happen at the cellular level in the tissues. But the heart, the brain, they depend on that circulating free T3, that marker that you're going to test for. So therefore, collectively across many cells, the organ itself can slow down function if circulating free T3 is insufficient, meaning it's not optimal. Could it fall into the standard lab value reference range of 2.3 to 4.5 on most standard? Sure, you can have somebody come in at a 2.4, a 2.5, a 2.6. They're not going to feel good because it's way below optimal. But yes, it could be quote unquote normal or within normal limits, but that it does not provide enough circulating free T3 for the organs of the body, and those organs can slow down. So we're going to give you some scenarios. Okay, scenario number one, you're sitting there, consultation, new client, they show you their labs because now you're going to look at thyroid labs on everybody. And they have optimal TSH below 2. You're like, oh, this is great. Free T4 is a 0.9. You go, well, there's that 1.5 thing, but we're going to look at the rest of your labs. Free T3 is a 3.7. Woohoo. Reverse T3 is a 9. That's beautiful. The antibodies, both at 0. No Hashimoto's present. This is fantastic. So if your client feels great and the labs look like these labs above, then if they're on medication, you leave it alone. Maybe they're on T4 only. This could be that 1 in 100 case where they're on T4 only and they feel great and they're great. So just monitor those conversion factors. Look at their selenium, look at their iodine, look at their zinc, look at their mag, check their insulin, keep their blood sugar in check, change their diet if they're insulin resistant, because that will push up reverse T3. Scenario number 2, TSH below 2. Great. Free T4 is 1.8. Okay, well, that's above the optimal range. But wait, earlier in the presentation, Dr. Amie said if free T4 keeps going up, reverse T3 might go up. So let's look at everything. Free T3 is a 2.5. Not good. Within normal limits, not optimal. And then reverse T3 is an 18. That's above the optimal range. TPO antibodies are 60, TGA are 200. That's thyroid peroxidase and thyroglobulin. Definite Hashimoto's here. You may need some T3, or you might need to put in some glandulars, but the glandulars contain T4. So you have to examine all of those factors that help convert. Because if you use glandulars to bring this free T3 up, that's great. But remember, there's too much T4 already, which is why the reverse T3 is going up. So if you use a glandular, that contains T4. So you might want to try to get this client's physician to write for that 5 micrograms BID of T3. Or you need to dive into all of those factors that help with conversion. All right, another one for you. TSH is a 2.8. It's above a reference range, above the optimal range. Free T4 is 1.5. Good. Free T3 is a 3. Almost there. Reverse T3 is a 25. But there's no indication of Hashimoto's with antibodies. Definite conversion issues present. You have to check those other markers because you can see, okay, the TSH is, they're right on that border, right? They're right on that border. And if you didn't test reverse T3, you would say, well, they're darn close to optimal. They're going to get there. They're almost there. I actually just had this as a patient last week after I made this slide, ironically. And the poor girl, she is 18, obese, hypothyroid, Hashimoto's. So she did have the presence of antibodies. Her reverse T3 was 25. So we go, okay, wait, she's actually on T3 only. So here's a real life scenario. She is on T3 only. She came to me on T3 only, a very small dose, but on T3 only. So her free T3 was okay. But when we looked at that reverse T3, hers was actually elevated at a 31. Insulin resistant, out the wazoo. Actually, she's basically type 2 diabetic, but nobody told her. A1C of a 7, insulin was a 26, I want to say. Severely, so that high insulin. And I told her and her mother, we have to get the insulin down. We have to change the diet. We have to use things like berberine. I know I'm getting off topic. We have to get the insulin down, but this is part of your job is to check those other markers and do what you need to do to get the insulin down, to get that reverse T3 down. Okay, I think this is the last one. So TSH, 2.8, free T4, 1.5. Free T3 is a 3. This is very similar to the last one. Reverse T3 is a 14. Oh, man, it's right there on the border. It's right there. No sign of Hashimoto's. Okay, what's the answer? I don't know. Maybe. It depends. What are their symptoms? So this is really where you take the labs, and this is where your client is more than a lab value, but those labs are going to help guide you. What are their symptoms? So if someone is coming to me, their labs look like this, and they're like, yeah, I am 40 pounds overweight, can't lose a pound, trying everything, nothing's happening, tired all the time, my hair's falling out, I count the hairs that come out of my head every day, I'm not sleeping well. Okay, well then we have to address this. Then this is not an optimal scenario whatsoever, even though it looks halfway decent on paper. Okay, this is the last one, I promise. TSH is suppressed. Remember we said earlier, if anybody's on T3 or if you give them glandulars, their doctor's going to freak out because that TSH is going to get suppressed. That's what happens. Let's go back to the med books. Let's go back to medical school and think about biology and how everything works. TSH is suppressed, 0.007. That's actually me, by the way. Free T4 is a 0.9. Free T3 is a 5.0. Reverse is a 6. It's under 12. Good. No presence of antibodies whatsoever. You look at these labs, you go, all right, this patient's on T3 med or they're hyperthyroid. That's where you have to ask those 4 most important words that conventional medicine fails to ask, and it's your job to ask. How do you feel? How do you feel? Because how you feel and what your symptoms are is going to tell us what this lab actually means. So if you look at this lab and your client goes, oh my gosh, I'm jittery all that same thing. Everything we talked about before. I'm jittery all the time. I'm anxious. My hair's falling out. I'm having diarrhea 3 times a day. Okay, they're hyperthyroid. But again, if you look at me, I'm on T3 only. Like I said, these are my labs. I'm on T3. I feel great. I'm optimal. Everything is fine. I'm not hyper at all. I'm just coasting along, living life, loving life. So you have to listen to the person, because if a doctor were to look at this, they go, oh my gosh, pull her meds, drop her T3, she's hyper. And the patient's going, what? No, I'm not. What are you talking about? So you have to be the interim and ask about their symptoms. How do you feel? So just so you know, if you use glandulars, if you use those supplemental glandulars, even if you use the T2, it's going to suppress the TSH. Because why? HPT axis, hypothalamic, pituitary, thyroid. Everything's cool. We don't have to yell at the thyroid. The TSH doesn't have to go up. It's going to be suppressed. Most doctors will panic. Like I just said, they're going to pull the meds. They're going to panic. They're going to freak out. They're going to call your client hyper. They're not. Most of the time, they're not. So you have to guide the client to refrain from meds or supplements 24 hours before those labs. It's not necessarily going to help the TSH, probably still going to be suppressed. But if you ever get a lab back and that free T3 is like this one out of 5, you have to ask, did you take your medication or your glandular supplement before you went to get your labs? Because T3 starts to peak at 4 hours, and this could be actually picking up on the T3 that's in your system. So ask them that, and then guide them to refrain from taking medications or supplements 24 hours before their labs. It's going to drop below a 0. TSH is going to drop below a 0. This is actually the desired result if someone had their thyroid out due to cancer. We want to suppress it so that no tissue regrowth occurs. It does not mean, again, that your client is hyperthyroid. Medication type and dose is very individual. People ask me all the time, well, what's the roundabout dose I should be on with these ancestral glandulars? What's the average dose of T3? I don't think. No, there is none. What works for you might not work for somebody else. I've seen patients optimized on 30 milligrams of a glandular. I've had patients optimized on 180 milligrams of a glandular. I've had patients optimized at 5 micrograms of T3. I take 150 micrograms of T3, split dose 75. I've been on it for decades, and that's what works. So there is no average dose. It's very, very individualized. And then you just have to determine glandular versus T2 from the labs and what you want to use. So there you go. Thank you so much for listening. I hope you got a ton of nuggets out of this to help you improve your client outcome, because ultimately that's what we're out to do. We want our clients to be better, and that's our job in this world. So thank you so much for listening.
Dr. Amie, that was incredible. I certainly got a lot of nuggets out of that, and I will be listening back again for sure. I took lots of notes. When you mentioned the frozen shoulder, that brought people to mind. So many pearls of wisdom in there, and we can hear and feel your passion. You can tell you've walked that journey, which is just incredible. I want to thank you so much. I know this is really going to resonate with our members, and I really appreciate your time here with us today. That was absolutely fantastic. I will be sure to share your slides and links, which will go under your presentation. So I want to thank everybody who's listening here today, and to remind you that this webinar can be viewed in the Members Archive along with other cutting-edge webinars. As mentioned, each webinar includes a corresponding quiz, which is worth 1 continuing education unit. So if you have an interesting topic that you would like to present, or if you know any other speakers you would like us to host, if so, please feel free to reach out to me by emailing andrea@namp.org. But this brings us to the end of our discussion. Thank you, Dr. Amie. Thank you, everybody, for listening, and enjoy your day.